Good afternoon, everybody. Thank you for joining this webinar. My name is Jeremy Hobart and I'm an MS neurologist based down in Plymouth, and I'm joined by three of my colleagues who in a moment will introduce themselves. This webinar is about formalising remote MS care and essentially around continuing to use the lessons that we've learned from this period of lockdown and change when we return to what is essentially going to be called normal practice. So we will have the structure will be a short presentation from David Paling, and then we're going to open out into a Q&A when we will have discussions amongst ourselves and answer any questions that have come in during that time. So if I can ask the panelists to introduce themselves, starting with David, then Wallace, then Daisy.
So hello everyone, my name's David Paling. I'm a consultant neurologist working at the Royal Hallamshire Hospital in Sheffield.
Hi there, I'm Wallace Brownlee. I'm a consultant neurologist at the National Hospital for Neurology and Neurosurgery at Queen Square in London.
Hi, I'm Daisy Cam. I'm an MS specialist nurse working in Sheffield.
So David, over to you, please.
Great, well thanks very much. Daisy and I have put together a couple of slides to share our experience really of the pandemic and what we've learned. And remote management isn't completely brand new to us. For a long time, we've been trying to remotely manage our caseload of people with MS. And one of the reasons that we wanted to do this is that our service, along with lots of services in the UK, covers a very large geographical area. And my furthest patient, so I'm sat here in Sheffield, and my furthest patient lives away in Market Raisin. That's about 60 miles away, and it takes about an hour, 40 minutes to drive. And this is the equivalent in London. So it's sort of like sitting at Heathrow Airport trying to look after someone from Canvey Island. And what do? Well, we spend a lot of time in the motorway. So as well as doing clinics in Sheffield, we do, as consultants, we do clinics in cities throughout the region. And actually the MS nurses have taken this one step further, doing clinics in GP surgeries and health hubs. But it's only so good. So it's a little bit better. It's like trying to manage my patient in Canvey Island from North London rather than Heathrow. But it isn't perfect, so that patient still has an hour journey to come and get me. And despite the fact that I leave the house before 7 on Monday morning and drive for an hour, she still has a burdensome journey to come and see me. And this all assumes that people with MS have comfortable, reliable cars, which often they don't. And these journeys can be several times more burdensome on public or hospital transport. And then the world changed, as did the way that we saw people in clinic. And we switched all our clinics to being remote, either telephone initially or much more recently via video. And we also changed our MDT meetings to being remote. And we're not alone. So this is what consultations in the NHS were like before the pandemic. The majority were face-to-face. And now almost all all outpatient appointments are done remotely. My experience when it works is actually really good. I think it can be really almost quite transcendentally wonderful. My patient can sit in complete physical and emotional comfort in their house with their family around. We can look one another in the eye and have a really good face-to-face discussion. And what I particularly liked about it was that lots of the peripheral stigmata of healthcare was stripped away. There was no difficulties in travel, there was no problems parking, there was no stress in finding the clinics. Patients weren't reminded of their condition by being surrounded in the waiting room with lots of other people with neurological disease. And it really felt like a pure, unencumbered meeting of minds. And with so many things, the MS nurses were very much ahead of us on this, and they've always insisted on doing their new patient appointments in the patient's home, which has really facilitated this. When it worked well, it reminded me of this cliche by William Osler: listen to your patient, he's telling you the diagnosis. And everything was stripped away. I just had to listen to my patient. I also noted that I get very much less in the way of people not attending the appointment. And I think that's important. It's hard and it's expensive to travel to a hospital. And I think DNAs often reflect socioeconomic disadvantage. This is a huge area of MS, and it was actually one of the subjects of the Raising the Bar conference, how we try and engage everyone with MS into our service. And I think remote clinics are one way of doing that. And this is a paper about that. And actually, I think currently we're only using the technology really to replicate what we were doing before. But actually, with distance being less of a barrier, that there's much more that I think possibly we could do. If distance was no longer important, so when I see a patient with neuromyelitis optica, I ask them to attend a specialist clinic in Liverpool. This is a really big ask. Patients often have to travel for several hours to get there. A couple of my patients have actually had to apply for grants to cover the cost of doing this. But people do this, and it allows a few doctors working in a centre to build up a true UK expertise, which is something that wouldn't really be possible if we were all just looking after a couple of patients of our own. And this is reflected in better care for the patients and also a research output that we all benefit from. And can we do something with some of the harder symptoms in multiple sclerosis that we all have to deal with? But there's pretty considerable uncertainty as to what the best treatment was. Things like oscillopsia, medication refractory pain, or these sort of weird presentations of multiple sclerosis that we never really know what we should be doing about, the BALOs, the tumor refractive presentations. And we could develop UK experts in these symptoms who, from their clinic room or even the study in their house, could assemble a critical caseload to observe and research from. And we're also free of other constraints. We aren't limited to how many people can join us. We can have lots of people in a single consultation to really try and understand the issues. And the converse is also true. We can broadcast to many more people. I often have similar conversations about management of fatigue and disease-modifying therapies, and I can have them to lots of people at the same time. But it's not all good, and I do think there's some real areas of concern that we as a community need to work on. Often we're let down by technical issues. It can be quite hard to see, it can be quite hard to hear, the sound can be delayed, the picture can break up. When you're speaking to your family, that's pretty irritating. When you're speaking to a new person with multiple sclerosis, it can be devastating, it can destroy the rapport. And this isn't a uniform phenomena. Older people, people who live more remotely, people who are poorer are much less likely to have, or much more likely to have problems with their equipment. And it isn't just me who's noticed this. Even before the pandemic, there was talk of a digital divide and the disadvantage that comes with being on the wrong side of that. And with increasing digitalisation of healthcare, we run the risk that this digital divide also becomes a cause of physical harm if disadvantaged people aren't able to access healthcare in the same way. And it's also difficult for people to use technology. So people with ataxia can't really use mice, they can't use touch screens. People who can't see can't interact with technology. And also what I think is quite important, people with MS often find it very difficult to interpret visual cues and emotional cues. And I think that's exacerbated when people can't see body languages. And I do think we need to think about how it makes people feel. I couldn't really find much evidence for this, but this is an article about someone's experience of being the victim of crime and how they felt their experience of digital technology in the courtroom. So the judge, the juries, all the court reporters felt that it was an unqualified success. Apart from the victim herself, he felt devastated by the experience and how inhumane it was. Lastly, there are things that you just can't do. I can't tell whether people have spasticity or weakness on what they tell me. Eye movements are very difficult to assess. Cognitive assessment, the neuropsychologists don't feel that they can do an adequate cognitive assessment remotely. You can't do a bladder scan. You can't teach someone to intermittently self-catheterize, although I think the MS nurses did have a go. And there are diagnoses that we make which, embedded in the diagnostic criteria, are signs that we have to pick up on neurological examination. So I don't think it's a panacea. But yeah, that's it. That's Jeremy, that's what I've learned. And I hope that provides a useful basis for our discussion.
Thank you. So can I come to you, Daisy, first, as someone who works in that obviously the same arena as David, to give your reflections on the positives and then the negatives from an MS nursing perspective.
Okay, it's been different. As a nurse, I don't think any of us ever expected to work from home, so it has taken some getting used to. To start with, our managers, nurse managers, were very anti us working from home and were much keener for us to find empty offices rather than decamping to our home bases. That's all changed this week, and now they're desperate for us to work from home. So we've battled with nurse management quite a lot. I think we feel as a team that the patients that we know well, that are regular follow-ups, have been managed really well over the telephone, and most of those patients are happy to remain on telephone follow-ups. What we've struggled with is initial meetings of patients, because like David said, we've always visited them at home, where you can pick up a huge amount of information, their living environment, what they might need in the future, their social background, etc. So that's been, I've particularly found that really challenging, to meet new patients on the phone rather than face to face. And I think the body language can give you an awful lot as well. You know, how frightened they are, how okay they are with it all. So that's been difficult. There are certain clinics that we haven't been able to run, and they're the more hands-on clinics. So the bladder scans, the ISCs, the acupuncture clinics, and we've also been discussing that we're actually finding the relapse clinic difficult to do over the phone, because I think really you need to be able to see a patient to know if they are relapsing or whether they think they're relapsing. You can't do an infection screen over the phone. So I think it's been 50-50 for us, really. I think the regular ongoing patients have been fine, but we're finding it a bit of a challenge with the more nursey, hands-on type of clinics. And I'm not quite sure how we're going to get those back on track, because I'm worried that we're going to lose them altogether, and they've been really vital clinics to a lot of patients.
Okay, so now to you, Wallace. We have been forced into a situation. As we come out of that, we have a choice. We have a choice that allows us to manage some of the negative sides that David and Daisy have raised. So I guess my key question to you is, what are the sorts of things that you will keep, and what are the sorts of things that you will revert back towards the more normal clinical practice?
So I think that the best thing about this experience of COVID-19 is to show us quickly that we can work virtually and remotely, because I think otherwise it probably would have taken a decade maybe to get to this point and to accumulate this much experience. And one good thing is that we've all been thrown in the deep end all at once. It hasn't just been one centre or one area. And I completely agree with so many of the points that David made. There are so many benefits to patients from remote consultations, but there clearly are some negative aspects as well. And I think it's been mentioned already, but seeing someone to make the diagnosis of MS, I think that really has to be done in person, because it's such a huge part of or such a change in someone's life. I think there's been research in the past that sort of indicates that how well the diagnosis is made actually will influence how that person might adhere to disease modifying treatment and engage with their MS care in the future. So we've got to get that right. And I think I've struggled giving that diagnosis over the telephone, as I've struggled giving other difficult diagnoses in the last couple of months. I think also something I've noticed is choosing disease modifying treatments is another thing that I think is best done face to face. And I think some of the body language that was mentioned is just it's so important to pick up on. You talk to some people about PML, and you can tell from the body language immediately that this is not something that this person will not consider any drug with any kind of risk like that. And other people shrug their shoulders and say, "Let's fine by me, bring it on." And I think that you lose some of that when it's done on telephone or by video. On the other hand, there are many people who come to our clinics with MS who increasingly in the era of effective disease modifying treatment might travel, as David says, half an hour to the hospital. I'm generally running not too bad. I'm usually on time, but a lot of my colleagues are always running an hour late. But they might wait in the waiting room for an hour, and then they'll come in for 5 minutes to tell me that actually they've been fine in the last year, no MS symptoms, treatment's going well, they're looking forward to a holiday in Spain. That'll take 5 minutes and they'll be out the door. And I think some of those routine follow-ups are definitely the sorts of people that we'll be wanting to do remotely in the future, for sure.
David, what sort of feedback have you had from patients?
So in general, the feedback's been good. They, as part of the telephone consults, as part of setting up the video clinics, they are asked after the clinic of their satisfaction, and satisfaction's been good overall, particularly for follow-ups. I think where you've already had a chance to establish a relationship, that actually, as Wallace says, you're just building upon that, and you can use video perfectly well to do that. It's been it's still been good, but not quite so good for the new patients. And I think Wallace is right. It's very hard to build rapport, particularly where you have a very, very difficult subject to broach over what's still quite a disconcerting technology for lots of us, myself included.
Daisy, a lot of interactions with nurses have been by phone, and yet we're using more video techniques. Are you looking to move your phone calls to videos? So
we piloted it last week. So 2 of our clinics we did via video link. I think they were mixed, really. Some of our patients didn't have the technology. One of the elderly patients, they just had the phone or their laptop pointing up to the ceiling, so you couldn't see the patient anyway. One didn't connect, one kept freezing. So I think that's something that needs to be improved. If it's going to work well, it needs to be improved from how it is at the moment. But I do think that's probably the way that will go, and I think it is, at least you get some face-to-face interaction that way rather than just a voice on a phone.
So those are clinics.
Yeah.
What about the daily phone calls that come in? Would you see those being moved to videos as well when they're longer?
I don't think so. No, I think
is that a volume of calls?
It's the volume of calls. Yeah, there's a lot.
Okay, so Wallace, you talked about the common occurrence of someone who's well treated coming for appointments, and they're well, they've had no new symptoms, they've got stable imaging, and they're clearly well managed. In terms of making those future appointments more remote, what issues do you see in the kind of routine measurement side that is going to fall? So I guess it's the neurological examination issues, and how do you see that being overcome?
So I think that you're right, Jeremy, that we are missing something by doing all this remotely. And we've got a requirement through BlueTech that we do an EDSS every year. And I guess in some clinics and some centres that's done more or less robustly than others. But there are ways of measuring disability remotely with the telephone EDSS, for example, and I think even the self-reported EDSS that is freely available has quite a good correlation with the neurological examination. I guess something that we've been wanting to work more closely towards is assessing disability in a more holistic way than just the EDSS. So something we've had discussions about at our centre is, how can we be getting patients up for a time walk test, 9-hole peg test, thinking about increasing focus on upper limb function for people with more advanced disability. Can we get an SDMT done each year? And I think that those things have had more challenging to do remotely. There are some promising tools for cognitive assessment patients can do at home, and there's the home-based 9-hole peg test and things. But you're right. I think that we will be missing some aspect of that by just a quick telephone call. I think another thing that I was reflecting on, actually listening to Daisy and David, was, I don't know what other people are finding, but sometimes the telephone conversations are quick, even in people who aren't usually quick at the clinic. And I think that process of coming to the hospital and waiting to be seen, patients often develop a bit of a script in their head about what they're going to bring up today. It's a chance to reflect on this chronic illness that they're living with, that actually they may not do when they're just getting a telephone call. So for example, I rang someone the other day and she wanted to do her consultation while she was away doing a walk. She was out in some fields. And she knew what time the consultation was going to be. I was running on time, but we did the consultation while she was out having a walk in the fields. And that's great, but it does make you wonder whether she's putting the same effort and concern into kind of reviewing her MS that year as she was in 2019 when we spoke.
So just a last bit around that question is, do you think seeing people annually is enough? Or do you think it's possibly too much? If you could remotely interact with them every 4 months, would you see that you could actually move the face-to-face appointments out longer?
I think that's possible. I think that for a lot of the NHS to move to that sort of system would be an enormous amount of upheaval with kind of job planning, and trying to make all that work would be difficult. But I guess more frequent, shorter contact with people can be quite useful, and not so much in MS, but in my general neurology practice, for people that are, for example, having frequent presentations to hospital and so forth. Actually, I find seeing the patient every 3 months rather than once a year can actually prevent hospital admissions and keep them on a better track. So I think there may be something to be gained from that.
Okay. Daisy, there's a lot of talk about home infusions and moving to home infusions. And part of that, I guess, is going to be imperative in view of the social distancing issues. Now, home infusion sounds fantastic, and I think it would be certainly for the person who does or the people who do our scheduling locally, it's gold dust. But do you see there are downsides?
I do. I think the downsides are that it's a specialist infusion unit that we have a neuro infusion unit. So the team of staff there know the patients really well. They know what to look for. They know the signs. They recognise if that particular patient isn't well. I think, to me, the worry with home infusion would be it could well be pharma-led, which opens up a whole can of worms, in that if it's an infusion nurse rather than a neuro infusion nurse, they may not know the patient, they may not know the drug, they may not really know what to look for. So I think there's big pros and cons. I mean, what I think would work better would be to move infusion units out to maybe more DGHs or clinical areas outside of the main hub, so patients aren't having to travel for an hour to the hub unit for their infusion. They could have it more locally. To me, that would, with the team from the current team going out to those hubs to infuse, rather than nurses that may know nothing about that infusion or about neuro.
David, any thoughts on that from a the neurologist's perspective?
Yeah, I think it does give us a chance to rethink the service and whether it is genuinely helping people with MS. It is difficult. There are issues of oversight at the moment. With everyone coming centrally, we have oversight. We can go and see people very easily, and we'd have to work out how that would work in a more distributed model. But overall, I think this is probably the prompt that we needed to rethink the historical way of bringing everyone into the same place to have their infusions. Now we're more comfortable with infusions. We have far greater volumes. And we have gained quite a lot of expertise in how to manage infusions and who is at high risk and who's at relatively low risk.
So there's some questions that have come in from the participants. There's one for you, Daisy, here, which is essentially saying that there's an advantage in more distance and remote clinics for people who are more disabled. So how do you judge who that is suitable for and who it's less suitable for?
Going to remote clinics, do you mean?
Yeah, so the issue here, and it's come up quite frequently, and it's something I think we all recognise, is that for some people getting to a clinic is really tricky. And those clinic appointments are, for the energy and effort, they're relatively short. So the remote option does sound very advantageous, but there's always a trade-off. And I guess it's trying to pick the right people for the right circumstance. So what in your mind, from a nursing perspective, would be the people who you really wouldn't want to be having remote clinics with? Obviously, deaf people and blind people will be less good, but you know, in the kind of broader scheme of things.
I mean, we've always done remote clinics, so we've gone out to all the we do remote clinics across the whole of South Yorkshire. So we do them in the DGHs, but we've also taken GP practices in those remoter areas for that reason. So the patients that live in the remoter areas can get to a much nearer clinic without having to travel.
I'm particularly thinking of distance clinics by video and phone.
Oh, sorry.
Rather than by because I guess one of the issues here is that as the disease increases, the number of treatments increase, the intensity of the work increases, but the teams are not expanding to the same rate, then by definition, we are going to have to change the way we work. So I can see us doing many more clinics from our offices with video, telephone, etc. And I guess my question to you is around the trade-off that brings. And in the more disabled people, who would be the people who would worry you about that sort of concept?
I think the patients with things, bladder problems, I think we would definitely need to still see them. I think patients who need pain management, we would need to physically see them. I think the patients who are starting on disease-modifying therapies that need teaching how to inject, for example, we've been doing those over the phone, but they're quite difficult to do. Trying to teach somebody how to put a pen together and inject when you can't see what they're doing, you've no idea that they've done it correctly. So I think we would want to see them. Acupuncture patients, obviously you can't do that remotely, but I think we know our caseload pretty well, and I think you can actually gauge quite a lot from a phone call as to who you have niggles about, who you possibly want to see if it was possible, and the patients who you know are probably okay. So I think you can gauge a lot from asking particular questions over the phone, but it's difficult at the moment to know, because we have an option once we've spoken to that patient whether to, as a follow-up, whether you tick the face-to-face or the telephone follow-up. So we've actually started to ask patients what they would rather have as a follow-up. Would they be happy with another call, or would they like to see us? and it's about probably 70% are saying yes, a phone call's fine. But surprisingly, for me, some of the patients said, oh no, I'd like to see you next time. So I think we have to just go with what we feel about that particular patient, what their views are, and what we're needing to see them for. And I think, like I said, the more practical things, we would need to actually see them face to face, if possible.
Jeremy, can I just add one thing there? I think Liz Wilkinson's question on this also raises an interesting care model, which I think she was suggesting that actually maybe a remote consultation can be done with the consultant, where a community-based MS nurse is with the patient. And I think that would be a fantastic step forward really for MS care, because a lot of people stop coming to the clinic when they get to the EDSS 8.5 mark. That's just such a turning point. You know, carers can't be arranged to be there for 7 a.m. so that the transport can arrive to bring people to the hospital and so forth. And I think that one of the points that Daisy made before is that the nursing visits to someone's own home gives a completely different perspective of how someone is living and managing their illness than you know, the one day they come to the hospital and they put on their best clothes and makeup and looking great. So actually that is something that I think would be fantastic to take forward as sort of virtual appointments for people with more advanced MS that can be coordinated around community visits at the same time. Because I think getting neurologists into patients' own homes is unlikely to ever happen, but this is a way that we could potentially do that.
So while you're on that subject, neurological examination done via video, how adequate could it be?
Well, I think it depends on what you're assessing, right? So if you do teleneurology because you're a stroke doctor and the question is, does the left side of the body move, yes or no? Does the person speak, yes or no? I think that remote neurological examination is fine in that regard, but I agree with David that I think there's some aspects of MS that can't really be assessed remotely, you know, spasticity and things like that. I did manage to diagnose carpal tunnel syndrome remotely. I managed to get the patient to do their own Snell sign over the phone. But I think that some of the key decisions, you know, a person complains, for example, that their legs are heavy and stiff. Now that can mean they've got untreated spasticity, but you know, many times, maybe a third of patients with that symptom, actually they're just describing their legs are heavy and weak. And you know, you might suggest putting them on baclofen, and that, you know, if someone rings up and says, I've got stiff legs, but actually without examining them to know what their tone is and their strength is, you could do the wrong thing quite easily.
Okay, so the next set of questions are kind of around how to involve patients in decision making on the on whether their ongoing management should be remote or not. So you were saying, Daisy, that you essentially ask people how they want their care to be?
Well, we're asking people. I don't know what we're asking people, but we haven't been told to ask people. So that could all backfire quite massively, really, if we're told we're not allowed to see them face to face. But just for our own interest, we're asking people just to gauge people's thoughts, really, because it's such a different way of working for us and for the patients. So, I mean, who knows where we'll be in 6 months, but I'm hoping that we will be able to see a small, you know, that 30% of patients face to face, but who knows?
And Wallace, for you, are you getting the same vibes from the London contingent as they are from the hardy Northerners?
Yeah, I think that most people at the moment are very keen to continue to have virtual or remote consultations, but I think part of that is also the fears about social distancing, you know, fears about coronavirus spread, and of course in London the bulk of people that come to see me will use some form of public transport, and people don't want to be on public transport at the moment. But I think the situation could be different in 6 months' time, and patient expectations and their satisfaction with remote consultations could change. coming back to your earlier point, Jeremy, about how to select people for remote consultations, I think that we need to take into account patient activation and use some kind of patient activation measure to try and guide this, because what we don't want is a whole bunch of people who are very, very motivated about managing their MS coming face to face, and a whole group of people who are not very active in their care and have a poor ability to self-manage having telephone consultations, because the outcomes for the already, people who are going to do well are going to get better, and the outcomes for the people who are maybe at risk of doing badly are going to be worse.
So there's another question which kind of is allied to that. So I'll stick with you if I can, Wallace, to start with. And this is the question is, do you think the MS charities could help in terms of helping people to prepare for virtual appointments? But I would broaden that out in, are you doing anything at the moment to help people to prepare for those virtual consultations?
So the basic answer to that is no. One thing that is interesting is that about DNA rates for the telephone, and I think David mentioned about this. I'm still getting DNAs, even if I ring people 5 or 6 times, and they're meant to be locked down, and I'm calling on the landline, but of course I'm calling from a restricted number, and people don't answer the phone because they think I'm trying to sell them PPI insurance or something like that, or saying we heard you had a car accident. And so that is one big issue, and one thing we've had discussions about is just actually writing to the patients or adding it to the text message reminder for the appointment that actually we are going to be calling from an unknown number, because I think many people are not accepting the calls. In terms of prepping people for the consultations, I think that we've had to change the way we work very quickly and go to this telephone or remote-based consultations. But if we are going to keep this around for the future, I think the point is well taken. The patients do need to be prepared for their consultations. They need to prepare and give themselves time. I don't want someone having their consultation with me in the work staff room with people coming in and out because they've not taken an hour or 2 off work to come up to the hospital for an appointment. So yes, I think that we probably do need to support patients, and whether that's through MS Trust, MS Society, or through hospitals, and to try and encourage people to get ready for their appointments and think about the questions they want to ask or what has been happening over the last few years, then I think that's really essential.
Okay. Same question to the Sheffield team. Any prep for these consultations that you've been doing, that you've required of your patients?
So no, we haven't especially. People have been asked to. They've been given a letter explaining what's happening. People do have the option to try out their technology. So there is a person that they can try the technology out with, and a few of my patients have done that and found that to be helpful. But I think as we're finding your feet, I agree with Wallace that actually sitting in the waiting room is an incredibly uncomfortable experience, but it does focus your mind as to what you want to talk about, and perhaps asking people just to set aside 10 minutes before their consultation, just to really think about what they'd like to discuss, how they'd like things to go. Actually, we do have the advantage in these appointments in that people can be at a place that they're very comfortable, they can be surrounded by their note. Perhaps we ask people to just spend 10 minutes before their allocated time of the conversation to think a little bit about what they'd like to discuss. And actually I found some advantages. People can can be in the consultation, they're in a place of comfort, but they're also surrounded by their old notes, by their medications. So that there are advantages to people being at home as well, and that they can refer to things that they wouldn't have been able to do should they've come to visit us.
Okay.
I think one more point. Sorry, Jeremy.
Something
that David just said made me think too about the waiting room is that Actually, the waiting room, one of the great things about it is there's the opportunistic care that can arise from the waiting room. It's the smoking cessation people who are doing a blitz that week and going around offering everyone nicotine replacement therapy who's a smoker, or it's the clinical research fellow that's trying to get 5 people for an MRI study who've got secondary progressive MS, and if you cold call them, they're probably going to say no, but the fact that you've met them in the waiting room and offered to make them a cup of tea while they're waiting, they'll sign up for anything. I think we've also got to think about how we keep that going in a virtual way as well.
Okay, so the next question, which ties into the previous discussion, this process has highlighted further the problems with capacity. I would love to speak to everybody every 4 months, but don't currently have the capacity to see people annually as it is. Lots of feedback that the average phone call and video are not that much quicker. We are looking at ways to manage this capacity issue. Have any of you any experience in using questionnaires to identify who needs face-to-face or even routine follow-up at all? I mean, you're all cold on that. I can tell you what we're doing locally for what it's worth, and we have exactly the same sort of issue. So to describe our population, we've got 1,773 people, 1 part-time consultant, 3 part-time MS nurses, an increase of 13% per year in our caseload. So we cannot manage the capacity. And we have exactly the same issue here. So what we're bringing in is a telephone screening call. The aim of that screening call is it should be 10 to 15 minutes. And if the call is longer than that, then that person needs an appointment. So the idea of the screening call is really to pick up on the issues you mentioned, Wallace, the person who's well treated, well managed, stable and well, who doesn't need more than a catch-up, versus the person who has new problems. So we've just started trialing this process, but part of the setup for this has involved trying to get people to complete EDSS online in advance, and also we've sent them to start with a thing called the symptom screen, the NS symptom screen, which is just a useful indicator, I think, of problem areas and level of problem. And I know that there's Novartis are in the process of trying to develop a performer to try and detect change over time, because that is essentially, I guess, the key issue for people is there a difference between where they are and where they were? So what about you guys? What are you thinking of doing? Wallace?
Jeremy, I think your streak's ahead of us as usual, I'd say on that. But I think that we probably, capacity is something that every MS centre in the country struggles with. And I think the answer to capacity is to really be developing better defined patient pathways, and trying to make sure that the patients that we put in front of, say, a very experienced therapist who can do an annual review, or a nurse specialist, or a consultant, that we're all, playing to our strengths in that. And I think that, there are very clear groups of patients who attend the clinic. There are a group of people who, for whatever reason, got very mild, or I don't like the word benign, but people who've had MS for a while and keeping quite well, but they need a point of contact and a touch base each year, just so they're in the system, because we know if we discharge them, they'll wait 3 months to be put back in front of someone. Then we've got people who are on disease-modifying treatments, many of whom, thankfully, these days are quite stable, and it's about making sure that treatment's appropriately monitored. And then a group of patients who are unstable on disease-modifying treatment, they need to be seen rapidly, and they need to be seen regularly, often, until they're stabilised. And then patients with progressive MS. So I think really we have to kind of work on developing more defined patient pathways so that we can deliver the right care for the right patient at the right time.
David, Any kind of structures and plans locally?
No, we don't, and I think we will be looking at the results of your pilot with Neurologist. We have the same issue that our patient numbers are going up 10% a year, and we don't have 10% more time, or we're not 10% more efficient. And I think this pandemic does give us the opportunity to look at what we were doing. And how we can do things better. We are looking increasingly to discharging patients to sole MS care to free up some physician time, and that's been going very, very well with close working with the MS nurses. And I think we can do more. And I think actually our hands have been tied by Blue Tech and the requirement to do an EDSS. But I think an MS nurse is perfectly able to assess if someone's doing well on a disease-modifying therapy and refer them for a consultant opinion if they're not, and continue to monitor them if they are. And I think this pandemic gives us an opportunity to look at those requirements for the Blue Tech form and a formal EDSS every year, and see if that could be adjusted, because that would enable us to free up more capacity.
Daisy, from an MS nursing perspective, any kind of?
Yeah, I think as numbers have increased and we've decreased, we're seeing patients less than we used to. I think historically we'd see patients every 6 or 8 months, whereas now it's yearly and sometimes every 18 months or every 2 years even. And you know, the majority are fine with that, because they know they can contact us in between if things aren't good, and they do that. So I think that's the way we're going to have to work. We're going to have to see patients, make contact with patients less than we potentially like to, but it's the only way of maintaining a service.
Yeah. So there's a great comment that's come in actually, but it's, you know, it's something that I've been thinking about for a while. The comment is around, you know, historically we've been encouraged to move away from a hub and spoke mechanism. So there's been lots of criticism of neurology services being delivered in a hub and spoke mechanism, and that we should move away from that. But does actually have the lessons of the last few months raised that a hub and spoke mechanism may actually be preferable in MS management? Wallace?
Well, I think hub and spoke makes so much more sense really in a lot of ways. But the issue in most areas, maybe Sheffield sounds like they've got their act together better than other parts of the country, including London. But the problem is there's been a lot of investment at the hub, and so the hubs have got big congested with patients, and we're having difficulty moving patients back to the spokes who don't need to be at the hub. And so I think that's a big piece of work to take forward. But I'm a big proponent of hub and spoke working, except we're the ones that should be going to the spokes, the doctors and nurses, not the patients coming to the hub.
Yeah. Okay. Comments on job satisfaction over the last few months. Has your job satisfaction, question to each of you in turn, we'll start with you, Daisy. What's happened to your job satisfaction in the last few months?
I don't think I should comment on that, really. It's not been good. It's been like for everybody, it's been incredibly stressful with them. You know, we were going to be redeployed and we were all trained up, and then suddenly we weren't redeployed. And, you know, initially they didn't want us working from home. Now they do want us working from home. It's just all been really quite stressful, and we've felt as a nursing team incredibly unsupported by our nurse managers, very unsupported. So it's not been great, but things can only get better, hopefully.
Wallace?
Look, it's been good and bad, Jeremy. I think that the NHS to work in at times can be quite frustrating, because trying to bring about change in big organisations is not straightforward. And I think that the thing that I feel heartened about is that actually the organisations that we work in do have the capacity to change and to change quickly. But I think that on a personal level, some days I've felt a little bit like a call centre worker. As I demonstrated on a call, I think the other night, I've got a headset now with a little mic and everything, because I want my hands to be free so I can type and prescribe while I'm talking to the patient. But one of the reasons I got into medicine, and one of the reasons I wanted to become a neurologist, I quite like being around people, and I think there is something different about this remote working. That will be a period of adjustment if it's going to be a substantial part of our job in the future.
David, you always look very relaxed. Have you been continually relaxed over the last 3 months?
No, not really. So I found this very unsettling, and I think it's the largest unsettling period of my career. But a few things have provided me with some hope and optimism for the future. The first is that we have been able to try out a new way of working, and I have found that when everything works well, and when you do get a good stable video connection to someone in their living room who's well prepared for your visit and has their family around them, I found that to be an incredible experience, and actually more gratifying than a more traditional experience where I demand someone comes to see me in my office and they have a stressful time getting there, and the whole healthcare apparatus causes them additional stress. I found that much better and rather gratifying. And the other thing, I think hospitals are quite nice places to work in, because they are full of people who generally act fairly flexibly out with their managers to do the best for their patients. And I think we've seen some of the best of that in this pandemic, and that's been hugely gratifying, despite all the personal challenges that we've had to go through.
So another question, and in fact the second half of the one on job satisfaction is around the implications for training junior staff of being well, I guess us being more based distantly from each other and less face to face. So Wallace, do you think this is impacting on junior staff training?
Yeah, I think it's probably quite a difficult time for trainees in particular. So many of our trainees were redeployed and they've come back, and some aspects of what they do is much quieter than usual. So for example, because of social distancing, our day unit is much quieter than it ordinarily is. We've got fewer patients coming in for planned admissions, for investigation and so forth. So that has training implications. And then I think there's also that part of our training as doctors where you go and see a patient and then you have to go and present the patient to your consultant, and the consultant comes in and sees the patient with you, and then you say, what do you mean there's nystagmus? There's no nystagmus here, you've made that up. And I think the educational aspect of that is something that needs to be considered. How we're working in the clinics at the moment is the registrar is in the room next to me, and we're maybe a bit behind other centres in terms of video, but they talk to the patient generally on their personal iPhone with a blocked number, of course, and they bring the iPhone into my room, and then we all sort of talk together, and sort of how it works. So we've tried to replicate as much as we can, that present the patient type model, and then a bit of discussion once you've both seen the patient together and talk about the learning points. But it is difficult, it is challenging.
Yeah. Just for the listeners, other types of phone are available. Daisy, in terms of training junior nurses, one thing you said was in terms of judging people for suitability for remote and face-to-face follow-up, for example, and you made the point that your caseload very well, and your caseload very well because you're a senior nurse. What about the junior nurses coming in? So the issue then is around is training issues for junior nurses. Is it different to Wallace's description of what it's like medically?
At the moment, we don't have any junior nurses, as in the team is well established, but I am quite worried because next April we have a full-time member of staff retiring, and what we would normally do with a new MS specialist nurse is they would shadow us in turn for a good 6 months until they felt ready to fly alone. And I really am unsure as to how we will do that if the full-time member of staff is replaced, which we're hoping she will be. How on earth we will train a nurse up, because it's not the same on the phone. Yes, they could listen into a phone call, but it's just not the same at all as sitting in with nurses in clinic and seeing that person face to face. So I think it's going to be a huge challenge, really, and I haven't quite worked out how we're going to do it. But I am hopeful that by then we will be doing at least some clinics. So possibly they'll have to get a lot of training in those. But I think it's going to be really difficult.
And it is.
Maybe the job itself. Sorry, I was just going to say maybe the job itself will be very different from how we've all worked. So maybe it won't be as difficult as I am envisaging.
So at this point in time, are you encouraged to have all your interactions by phone or video, or are you allowed to decide who you ought to see face to face?
No, that is all telephone at the moment. So some clinics have stopped altogether because they have to be face to face. But apart from that, it's all telephone.
Okay, it's interesting, isn't it? Because I guess we're given the freedom to decide who ought to be seen and who doesn't, and who you can manage remotely. We've had no emphasis or pressure on that at all, really. There's been a desire that non-urgent people may be appropriate for telephone or video follow calls, but there's been no kind of edict that you must. So I find that more interesting, actually. I guess at one level I'm a little surprised. So a question for the neurologists. Do you think this will change DMT prescribing? Now, that question is different to the impact of COVID-19 and the fact that we believe some of the drugs that we use put people at higher risk. But do you think otherwise the use of kind of remote interactive mechanisms will influence prescribing? Wallace?
I think to some extent, but it's a little bit difficult at this stage to separate that out from the effects of COVID. So, because of the ABN guidance, for example, around cladribine, which I totally disagree with, the patient needs shielding for 12 weeks afterwards. Many people aren't going for that drug, at least in my experience. But I wonder the effects of COVID and potentially this remote management issue as well, whether there might be a bit more of an upsurge in lower efficacy treatments. Patients can, if they want to start on Copaxone, they have a full blood count and some other blood tests with their GP. They have attend anywhere video consultation with one of our nurses who shows them how to inject remotely, and they get on with the treatment, as opposed to the workup for some of the higher efficacy treatments that might involve in a blood test that the GP doesn't want to do, like the quantiferon gold, for example, or the patient needs to go and have a cycle smear, or some other tests that are required, and then they need to travel to the hospital for an infusion. I think in my mind it's too difficult at the moment to separate that question out from the impact of COVID-19 itself.
David, any additional comments on that?
Yeah, I'd agree with Wallace. I think it's very difficult at the moment, but I do anticipate that this will make people feel differently about the infectious risks of treatment. I think previously people have been incredibly unconcerned about the risks of the infections and some of the more in more aggressive treatments. And I think that this is going to leave a psychological scar on people for a couple of years to come. And I think we may get a recurrence of some of the older treatments. We're using a lot more interferons, dimethylfumarate and natalizumab. And those patients may well stay on those treatments and carry on those treatments. So I think we will see this having an effect upon people's prescribing. And then, people talk to one another and they talk to their friends, and that peer group sometimes has an influence on people think treatments that people decide.
So while you're there, David, there's a question here that says, Dr. David Paling would like to answer this question live. Due to COVID, we had to stop our fellowship programs. What's your experience with subspecialty programs? Yeah,
so I mean, it's a real issue, isn't it? And I think we're just going to have to learn to use the technology to support it. So whilst on one hand we're losing the opportunity for people to have occasional interactions when they're sat in clinic today, we are actually, particularly when you do video clinics, you're creating a lot of useful teaching materials, and we're just trying to work out with the Attend Anywhere system. You can have lots of people attend on an appointment. So it could paradoxically be quite a nice way of being able to teach medical students. They'd be able to watch the consultation, but they're not in the same room getting in the way of the patient when they try to walk to the examination couch. And it's rather intimidating having 6 faces, but I could imagine lots of people would be happy for people to watch without their faces appearing, or just with their faces appearing in a small place on the screen. So I think we really have to rethink those programs, but I can see ways of using the technology, perhaps even to enhance what exists already.
So there's a question here which is really a comment I think we would all agree with. It is, how can you appreciate if a patient's progressing from relapsing MS to secondary progressive MS if you don't examine him or her for a long time? The moment of transition can skip and the treatment can come too late. I think that's very pertinent, but I guess I would also say that people's examinations stay similar and their symptoms get worse over time. And I think this is something that Novartis are trying to address a little bit, I guess, with a view to Siponimod coming online later this year, we assume. But they have they've developed a questionnaire that looks at change in symptoms over time that helps to detect this moment of transition. Although there's also the work from Roche and the ocrelizumab studies talking about progression independent of relapses in people with relapsing MS who may not be labelled as secondary progressive MS. So I think this is a tricky zone, but it's very pertinent, I guess, that the face-to-face interaction and the examination is an integral part of trying to understand where somebody is in their MS journey. And I guess it's something that historically we've become very reliant on, although now at one level we will have to rethink some of our issues. Okay, so there's a question here. I guess it was addressed a little bit in some of the stuff, but we might want to address this head on. I'm going to come to you first, Wallace, if I may. So when kind of face-to-face interactions are considered appropriate, or more appropriate, who will you prioritize restarting in your clinics?
So we've looked at some of this in our recovery planning already, Jeremy, and I think most of us feel that the people to prioritize are new referrals rather than follow-up patients, and that's because there might be a diagnostic issue, I would always examine the new referral, whereas many follow-up patients I may not examine, or I'll just do quite a cursory neurological examination. And the new patients attending might have a new diagnosis, or there might be some decision to be made regarding the treatment, all of which I think is better in person. I think, I'm not sure if it was Daisy or David, but someone mentioned about the relapse clinic as well. And I think that they're another group of people who you really need to see face to face. We know that, like TIA clinics, many people attending an MS relapse clinic aren't experiencing a relapse, and I think that the in-person assessment of that, not just the neurological exam, but getting the urine dipped and actually just finding out and being able to see what's going on with the person is really, really helpful. So I think those two groups of patients, I think, should be given the highest priority, and a lower priority, I think, clearly to people who are shielding, for example, who have already had treatment or may have more advanced MS and should be kept away from the hospital if all possible.
Daisy, from the nursing perspective?
I think definitely the relapsing patients, and we've already talked about how we could do that clinic in a new model. So perhaps having the neurophysio on hand at the same time, and at least one consultant, not necessarily that particular patient's consultant, but a consultant. And if we could set something like that up, it would be a multidisciplinary clinic, but purely for relapses. I think secondly, we would want to reset up the bladder clinic where we do bladder scans and we teach ISC. That's really important because those patients we're going to have a real backlog of those patients who actually, their bladders could be getting worse and worse over time, when it could be easily resolved by seeing them. I'd like to reset up the acupuncture clinic, which I do for neuropathic pain. I think that, again, there's going to be a huge backlog of those patients, and all the good that's been done from having regular acupuncture will have to start all over again. So there are three priorities, and also the teaching patients their disease-modifying therapy treatments, the injectables. That's quite tricky over the phone. So I think firstly would be relapse, secondly would be bladders, thirdly acupuncture, fourthly DMTs, in that order, I think.
Okay, so the second part to that question is to you, David. How do you conduct that safely?
It is difficult, and it's something that we've been looking at. We have a service that we're able to see patients face to face at the moment when we need to, and there's a number of checks that are set up on that service. So patients are phoned up the day before, asked for symptoms. When they come to the hospital, someone again at the entrance to the area where they're seeing asks about any symptoms and takes their temperature. They get a mask put on, and then the doctor who examines them is in the appropriate PPE and is able to see them. And I think that's probably what the model has to look like. I think we probably need to think a little bit about how we work, and certainly as MS consultants, we're talking about possibly just one consultant at a time running that service, but it being open to patients of all consultants where there is a need for them to be examined. And we're essentially the sort of the examining technician for that consultant. And I think we also need to think about how we make it a humane service, so people don't feel like they're just cattle being passed around. How we make it humane, and it is more difficult to establish a rapport when your faces are covered, when you're in a rather unfamiliar environment, and we need to think about that, and how we just try and make it as a nice experience as possible for people. But actually, people have responded quite well to what we've done so far with the with the face-to-face service. People are very, very concerned, and they are pleased to see that we take concerns about coronavirus seriously.
Wallace, anything to add on the safety thinking?
Yeah, well, I think that we've been looking at a few different things. So one of them is that obviously the social distancing required in the outpatient area, and one of the things that emerged in our hospital is many of the outpatient rooms didn't have windows, and so none of those can be used for consultations at the moment. And I think it's also highlighting issues for inpatient care as well. So we've got quite a big inpatient the neuroinflammation demyelination service at Queen Square. Often there'll be 5 to 10 inpatients under a number of consultants. So we're having to look at implementing, for example, an attending system for inpatients, because it's not practical to have a lot of foot traffic on the wards and lots of consultants coming on and off the wards and moving around and things. So lots of challenges for kind of keeping our patients safe.
And Daisy, so the MS nurses often will see more disabled people.
Yeah,
by definition will probably be at higher risk. So what about you? Your thoughts on the safety?
Well, up until the lockdown, we were seeing our very disabled patients at home. So the two groups of patients that we would do home visits on were the newly diagnosed and the very disabled that wouldn't or couldn't get to hospital. So I'm really concerned about that group of patients, because if we are unable to see them at home, or we're not allowed to see them at home, I wouldn't feel very happy. I don't think it's fair to bring them into hospital, especially at the moment. So that's another challenge I think we're going to have and look at, because otherwise those patients are going to get forgotten about.
So this is going to be the last question, because we've run over by 15 minutes, although we still have a lot of people listening. So the question is about remote computer systems to monitor people from a distance. And I guess we touched on this a little bit when we talked about preparation and questionnaires, etc., before clinics. But what are your individual views about remote monitoring systems in the management of MS? Wallace.
I think I've got limited experience with remote monitoring, but I think it's something we're going to have to embrace in the future. And the sorts of things that you mentioned already, Jeremy, for example, people self-monitoring symptoms of progression, for example, are going to be essential in the future, I'd say.
Daisy?
I agree with what Wallace has said, really. Yeah, almost identical. I think we are going to have to rely on patients a bit more, or believe them a bit more, as to what they're saying their symptoms are, or how they are in themselves, rather than us assuming that we're always right and they're not.
David?
Yeah, I think it's going to be essential, and the technology to enable people to do this is becoming better and more integrated in things like Fitbits and even in your mobile phone. And some of my patients are starting to do this. They're starting to provide me with their diaries from their phones about how far they're walking, how many steps they're doing. And it can be useful. It's not useful completely out of context. You do have to contextualize it. But overall, I think it does give a better overview as to what's been going on with someone over the last year, rather than just their recollection and how they are on the day. And I think, in 10 years' time, we'll be using this ubiquitously, and we'll look back on what we used to do with horror.
Yeah, and I guess that's part of the development process. So on that note, I would like to thank the MS Academy for hosting yet another enjoyable and we hope informative webinar. Daisy, David and Wallace for their participation and their honesty. Thank you very much.